All right, let me see. You can forward people to the oh god, you can forward people to the YouTube URL by putting in it in. Wait. We should be live right now. This is not good. Why can't I get on? Yeah, that would be. You have to put the URL in miscellaneous missed complete redirect. Do you know where that is? Where's miscellaneous missed? Missed webinar. Okay, edit. Miscellaneous missed complete redirect. Complete redirect. You have to put the URL, the YouTube URL. Okay, hold on. Let's see if we're getting on. Okay, nope, that's not working. Registration page, live. Just trying to get in. Okay, I can't see anything because I can't get back to my login. Hold on. Folks, we may be live. I just can't tell. Hold on. 1 second. Oh, this is always fun. Oh, here we go. Oh, so, oh no. Oh no. People gotta join now. That was... Hi, folks. Yeah. And now I'm getting a 503. I'm going to... Yeah, I'm getting a 503 because it's trying to send me through our website, and not good. And I have no idea whether people can see this. Okay, it does look like some folks are here. This is the strangest thing. All right. I believe that you can see this. I'm going to introduce Chuck as I try to confirm that we are actually live, and I'm going to let him get going. So thank you, you guys. I really appreciate you hanging out for a bit. We had some last-minute technical issues, but as far as I can tell, I think we are live. This is great. My name is Zoe. If you haven't been with us before, this is a Coaching the Body webinar. Today's webinar is the new self-treatment Secret to Fixing Shoulder Pain Without Seeing a Therapist with Chuck Duff. A couple housekeeping things. We would like you to be fully here with us as much as possible. So if you can just take a minute to disable any notifications and close out any browsers that may be distracting, would greatly appreciate it. If you have any blurriness or freezing during the webinar, please try refreshing your browser, which usually resolves the issue. If you do have some issues, stick around to the end as we'll be sharing our slides with those that hang out for the entire webinar. We are trying to keep the webinar to an hour. If you have questions during the webinar, you can enter them into the box. We may have some time at the end of the hour to answer a few of your questions, but otherwise we will be responding to them via email. So don't be discouraged if you don't get an answer immediately. Without further ado, let me unmic him and get you our host, Chuck Duff. Here we go.
Okay, thanks, Zoe.
No problem.
So we're going to get started. The purpose of today's webinar is to talk about self-treatment in our current environment. It's obviously something we have to adapt to, and I hope everybody out there as well. I appreciate your attending. So our principles that we have developed are equally effective. If you do it on your own, it's just they're definitely, with especially severe cases, there's advantages to being able to see a therapist, but most of us can't do that right now. So we're going to talk about shoulder pain. Shoulder pain has kind of exploded in the last few years, and I think a lot of that is due to mobile devices and postural issues, just overall stress. The problem, though, is that a lot of the way that the shoulder pain is interpreted is it's immediately judged to be an injury. Most diagnoses that people receive when they come in, they have a diagnosis of some type that is usually related to a disease or an illness, a torn rotator cuff or other torn ligaments and so on. That's just a pervasive view in the medical profession. So most people in general, in and out of the medical profession, assume that all pain is caused by tissue damage. That if your shoulder hurts, you think, well, and your doctor will say you probably have, some sort of bursitis, or you have an inflammatory condition, something like that. Now, those of us who do trigger point therapy, which I've been doing now for 20 years, we see this very differently. We don't see pain and injury equivalent. I did when I started out, because that's kind of, the prevailing view. But then I started realizing there's a really profound difference, where somebody feels pain, and just because they feel pain doesn't mean anything. It doesn't mean that that area where they're feeling the pain is actually injured. This is a very telling diagram that I like to use. I took this off clearly a surgical website. So it's types of shoulder pain. But when you look at it, these aren't types of pain. These are disease conditions, and inflammatory states. So bursitis, arthritis, tendonitis, it's all these itises. And, depending on where you feel your pain, they're going to say this or that bursa is inflamed. But they're not actually opening the shoulder up and seeing, is that actually true, And so at some point I started realizing, well, I need to just do my work anyway, and then kind of, see how it goes. And I started having really good results. So I started studying neuroscience, and then it totally changed my understanding of pain. And this really hasn't made its way into the mainstream, surprisingly. But Lorimer Moseley is an Australian physiotherapist and neuroscientist. He's somebody I've studied quite a bit. And he said some really profound things, like the idea that soft tissue damage is neither necessary nor sufficient for pain. So in other words, pain is really unrelated to damage. And pain is an output. So it's actually generated by the brain. You can think of pain as it's like your smoke alarm making noise when it senses that there's a problem in the house. Now, that may just be you cooking, or it may really be your house burning down. The smoke alarm can't tell the difference, but it puts the alarm out. And that's really what pain is. Pain is a way for the system to kind of flag a condition so that it can get our attention. So the way he puts it, it's an opinion rendered by the brain saying, is this really a dangerous situation or not? So I studied trigger point therapy. I started in about 2002. In my practice, I trained initially in Thai massage, and I was having trouble really, predictably resolving people's pain conditions. And then I started looking around for alternatives. Well, I discovered Claire Davies' book that he had just released, and that was just a revelation because, you can kind of see in the diagrams, there's an area where you might have a tender spot in a muscle, but then that tender spot is actually sending pain. The nervous system will produce pain that you might feel elsewhere in the body. And that was revelatory to me because I was seeing that a lot. I'd find areas of tenderness, but it wasn't necessarily where the person was feeling their pain. So this idea was really developed by MDs. Dr. Travell and Simons were they wrote the classic medical textbook about it. I went in and I studied all that stuff. And one of the things they say in Travell and Simons is, they surveyed in several clinics and found that trigger points are actually responsible for 80 to 90% of the pain that people have reported in these various clinics that they studied. And that's certainly been our experience, in our own clinic and my students and so on. So the whole idea of pain, it's sourced very differently than most medical people are going to assume. So the idea of referral, this is referral. So here we have the infraspinatus muscle, which is in the back of your shoulder. And where it actually causes pain is in the front of your shoulder. So, that right there is kind of a distraction that, a lot of people are going to be confused by that. Anytime you have pain in the front of your shoulder, people are going to go to your bicep tendon, and say you have bicipital tendonitis or you have bursitis, something along those lines. But actually, this is the most common cause, this muscle. So the X's are tender areas that are in hard muscle fibers. So these muscle fibers become contracted, and it sends what we would call a nociceptive signal. So nociception is not pain. What nociception means is it's like the oil sensor in your car saying to the central computer, there's a problem with oil pressure, or the smoke alarm sensing smoke. It's just paying attention to an indicator. Nociception is designed to tell the nervous system that there is a problem, but it isn't identified necessarily as an injury. It's just an unusual situation, let's say. Now, the nervous system then will generate pain, but it usually will be in a different place than the original trigger point. So often it'll be over a joint, for example, like your shoulder joint. And this confuses everybody. People that haven't studied trigger point therapy are going to, assume these inherent conditions in the joint, in the shoulder. It seems logical because joints, can cause problems when they do develop issues, and sometimes they do. But I'm just talking about statistics here. See, so you can say the vast majority of cases aren't because of an actual acute injury. What happens with pain when things have been around for a while, so let's say you start to develop pain, And then you go a week, 2 weeks, the body starts to upregulate. And that upregulation means it's becoming more sensitive. And you're going to start experiencing more pain. That's just how the system adapts, but you may not have started with an injury at all, because trigger points can actually develop just from simple overuse. You might hit the weights a little too hard, or do something in your yard or something that you're not accustomed to, and that's a start. That can start this process. So direct referral is this phenomenon of, here's the case of the infra where, the back of your shoulder, that muscle gets into trouble and gets a little overused. Janet Travell actually studied this muscle first because she was a tennis player, and she was finding pain in the front of her shoulder when she'd go to serve, because she was contracting that muscle, to raise the racket and go into the serve stroke. So she would find pain in the front of her shoulder. Well, then she found that there were areas of tenderness in the back, and she had her dad, who was a cardiac surgeon, inject those points, and the pain went away. That was kind of what started her on this whole process. So it was treating those tender points in the back of the shoulder that made the pain in the front disappear. Now, that's the simplistic view of trigger point therapy. If it were that simple, then we would all be fixing people in one session, and we'd be total geniuses. That isn't actually real life. It does occasionally happen that it's simple in that way, but most of the time it's not. And this is the problem. We have a much more complex network of muscles that refer pain over each other. So here's a case where we have a satellite referral situation where a muscle that's actually on your ribs causes pain that lands over your trapezius, and then the trapezius gets into trouble. So we call that satellite referral. So it's a chaining between several muscles. This is quite common. It seems very complicated, but it's actually not. It's very predictable. And so what I've done over the years is I've documented all the cases that we've seen, and we now have a very predictable set of patterns that we know happen in shoulder pain. And that's why our treatments are so effective, because we understand these satellite relationships. So what happens, I think, with trigger point therapy, if you've ever had a trigger point treatment, sometimes it can be initially helpful and then the pain just returns after a few days. Well, that's often because the therapist isn't really properly following satellite referral. This wasn't really dealt with fully in Travell and Simons, and they started it, but then they were getting older. They just didn't have time to really get into that research. We've really, over the last 15 years, we have researched this quite a bit. So here's a complete explanation here of what's happening. The serratus anterior, you might have your tenderness over here on the rib cage, but it throws its pain over the low trapezius. See, so then the low trap refers pain up, and you may feel it in your neck, or you may feel it in the top of your shoulder. So that seems very disconnected from the side of your ribs, but it's something that happens a lot. So it's a common pattern. In order to really understand the true source of pain, you have to know these patterns. And so that's kind of what we've done in our work, is we have documented this. Now, Dr. Lynn Chatow, proposed an idea that actually we found to be quite useful. And that is that trigger points aren't just simply, something malfunctioning, but they actually can be useful. When a trigger point happens, part of the muscle becomes a taut fiber. It's almost like a ligament. And so the body abhors instability. If you have a break or a torn ligament, you're going to end up with way too much motion, and excess mobility is not safe in the body, particularly if there's a severe injury. So we would wrap that and splint it, and the body really does the same thing, but it uses muscles to do that. So it can actually recruit trigger points into muscles to provide more stability across the joint. So you may start out with a fairly low-grade type of pain, and then you find in the shoulder that over time that pain starts to get worse and worse, and eventually you can't move your shoulder like you should. Somebody might say you have frozen shoulder. But actually, what in my theory, what has happened is the body has used muscles to split the shoulder joint. It's brought in a lot of trigger points as a way to provide stability. And then you end up with a very locked down joint. But in this approach, it's safer, because you can't move it around. If it was truly injured, then you wouldn't want to be moving it around. The problem is the nervous system can't tell the difference between that initial pain being just from trigger points and an actual injury. So this is what fools everybody, and I think it even fools the central nervous system. So we call our approach coaching the body, and what we're really doing is we are showing the central nervous system that it isn't actually injured, that the muscles can start to move again, and then once you start to get pain-free movement happening, then the system will start to down-regulate. It'll start to let some of these muscles go. It allows the therapist then to release those muscles gradually, and so it's a process of gradually, taking all of those adaptations back out again. And this is what I think frozen shoulder really comes from. The shoulder joint it's a very mobile joint, so it's very vulnerable to this splinting process. And then you end up with very limited motion. Any motion might tend to hurt. We've worked with hundreds of these cases very successfully by doing what I just said. We're starting to look at the presenting muscles, work with the trigger point, start to create more movement, and then the body starts to downregulate and it starts to let things release a little bit more easily. Now, you may have fascial change, so you may actually have change in the joint capsule, but I believe that that is also part of the body's adaptation to danger, so that will actually change. And I've had some very severe cases that were told they needed to just wait it out. I'll tell you about one in a little bit. And they ended up with really excellent results. If you look at, this is a sort of a diagram of a common frozen shoulder pain pattern. Well, you can call it frozen shoulder, but in our system, when you actually look at the pain patterns, two of the most common muscles in shoulder pain, the infraspinatus and subscap, if you look at the composite pain patterns of those muscles, the subscap sends its pain over the back of the shoulder and all the way down to the wrist. And then the infraspinatus is, the one I showed you earlier, front of the shoulder going down to the thumb side. Well, it looks exactly like what they're drawing here. See, so this is where people kind of miss the idea that muscles cause pain. That is really the central idea. And if you understand that, you follow the satellite referral, you know how to retrain the system, you can unravel this adaptation and give somebody results very, very quickly. So you have to understand the logic. And, I tend to think of the body as not just being this very delicate thing that breaks and, you need a new part. It's actually an extremely robust, intelligent organism. And so over time, these adaptations are sensible because of the need to protect against a perceived injury. So once you start showing the central nervous system there's no injury, then you can start to get that motion back again. So we've been very, very successful at this. So here's kind of a discussion of how this could develop, let's say. You go out and shoot some baskets, you're not used to doing that, you might have a little stiffness in your shoulder afterward, and then you find a week later that things are starting to get a little bit worse. Now that stiff shoulder has turned into pain in other areas, and any motion is starting to produce more pain, it's starting to ramp up, and then perhaps you find that your motion over a period of time becomes very, very limited. Well, this is this process where that initial overuse, it's not even an injury, it's just overuse. And that is a way to set up trigger points, because trigger points are really a metabolic overload. So the body can't get nutrients into the muscle fast enough for whatever you were doing. You might have a fall or demand a lot of the muscle very quickly. And if you're not an athlete who's training all the time, you just don't have the reserves and have the vascular reserves really to develop and bring those nutrients into the muscles. So then you develop trigger points. So it's really a crisis of metabolism at the cellular level. And then the body starts getting, from the trigger points that you've developed, it starts getting nociception. And it says, oh, there must be an injury. And so I'm going to start locking things down and bringing more muscles involved, and then eventually end up with a very, very restricted range. So the retraining, now this is something we obviously do therapeutically, but these principles can be applied for self-care. And that's what I'm going to talk about today. So we follow exactly the same analysis of where the pain comes from. And then what we try to do is we try to bring in pain-free movement as quickly as possible, using our techniques to release muscles gradually. And then as soon as the nervous system starts seeing that pain-free movement is possible, then you're on kind of a downward slope where you can release more and more and more and more quickly. Some of the tools we use, this is the Muscle Liberator tool, and it's a mechanical vibratory distraction tool. So by vibrating the muscle, people tend to use these just as massage tools and they just rub it where it hurts. Well, that doesn't do it. You have to have this analysis, and that's how we use these vibration tools. It gives the nervous system inputs that make it so that it's not going to have that ability to lock things down as easily. It gets distracted, essentially. And then it's a hack. It's really a neurological hack that allows us a way into the nervous system where we can start to produce change more quickly. So that's a terrific tool. I'm going to talk about using vibration for self-care in a little bit. So then we try to develop movement. We use balls and Theracanes and whatever tools we have available to compress the trigger points, provide distraction, and then we use what we call contract relax techniques to, it's another hack, another form of hack that allows the body to let go more quickly. And when you take our method of analysis and all of these techniques and put them together, that's what we call coaching the body. And it has been really super effective. So we're really exploiting what we call neuroplasticity in neuroscience. That's the ability, the brain, it's not a fixed set of wiring. It can change its wiring. It's like having a switchboard, and you can change the patching of the switchboard very quickly, even in minutes. Now, that can be good, or it can actually work against you. So in the case of chronic pain, where it's putting in new connections and it's like, oh, this is urgent and there's a problem, it starts to produce a lot of pain and, get this kind of crisis going on. That's not a good thing. That's where we have to insert these kind of neurological approaches and hacks that we use to show the system what's going on is not an injury that you need to protect. And pain-free movement is possible again. So at that point, we're getting the brain then to use its neuroplastic powers to unplug some of these wires that got put in and new synaptic connections and down-regulate. Now, the interesting thing about this is that stress, anxiety, emotional issues will contribute. And the limbic system processes all of that information in the same place as actual injury and other nociceptive loads. So, our environment where we've had to be dealing with self-isolation and, the COVID situation produces a condition of, everybody's kind of on tenterhooks now. There's a lot more anxiety. So you'll notice that just emotionally, but it'll also influence pain. And so it's a point in time at which we really need to have these tools. That's why we wanted to do this webinar at this time. You may have seen some of my videos on the internet. This was not a staged video. Sometimes people think she's a model. that was my second session that I actually did with Valerie, and she came to me with two frozen shoulders. She had been diagnosed in both shoulders. She was miserable. She had spent $10,000 in the last year and had no results, and a physical therapist had told her that nobody could help her. Well, she was brave enough to try me, and within a couple sessions, we really produced a lot of change. And that happened, in those sessions. So, yes, her shoulder didn't look frozen by the end of the session, but it certainly was at the beginning. But that's the worldview that I'm talking about. It's not because of fascial locking down. It's the muscles and the taut fibers and the pain produced by trigger points that was preventing her from moving. So we did a lot of work. When I was out in the Bay Area, I do some session work out there and some training in San Francisco. My daughter lives out there. And then Valerie flew to our clinic here in Chicago because she was seeing such amazing progress. And we actually have a beautiful video that we shot of her telling her story. And she went basically from sleeping in a chair or being about to lose her job to normal and skiing again. So she was very, very happy. She had to do a lot of self-care as well. We gave her projects of things to do, and we use these techniques ourselves. It isn't just clients, because we can develop problems too. So in the shoulder, what specifically are we talking about? Well, one of the keys that we have really focused on in the shoulder very successfully is what we call scapular positioning. So your scapula is your shoulder blade, and the muscles, you can see the slanted muscle, that's the rhomboid fibers. Those muscles contract. They can only contract. So when this muscle contracts, what it's going to do is it's going to bring your shoulder blade closer to your spine. And then it's got opposing fibers on the other side. That's the serratus anterior. So when the serratus contracts, it's going to do the opposite. It's going to tend to bring that shoulder blade around toward the front. And I think, you've probably observed in yourself and other people that people tend to get kind of a slumpy, rounded shoulder posture over time, particularly if you have pain. Well, that's because of these muscles and the trigger points that they develop. And that is actually the central problem. And these days, with mobile devices and, all the stress in the world and so on, that's why I think we have seen such an incredible ramping up of symptoms in the shoulder area. We now deal with a huge percentage of our cases are shoulder. So the shoulder blade is really positioned and controlled by a set of muscles that attach all the way around. So you can see the rhomboids here, the trapezius, we have serratus anterior, and the levator scapula. So these are all the muscles that you're going to be dealing with in the self-care. And it doesn't take much to start to actually allow that scapula to move properly again, because it does the same thing. The body tends to lock things down. You'll tend to get locked down and your shoulder might be coming forward, and it's really hard for you to even pull the shoulder back. Well, that's because of the serratus anterior and these muscles on the front that tend to contract and shorten. It's kind of a protective posture even. If you're going to protect yourself, you're going to do that. You're not going to open up your front, So I see it even as kind of a neurological instinct towards self-protection. So this is what we work with. We work with it in our therapy, and we work with it in self-care as well. And it can be really very, very fast. What you'll find is when you get the scapula moving again, I'm going to show you some of the things that happen here. So typical, rounded shoulder posture. Now in this case, she may be a hyperpronator. She looks like the sort of hypermobile body type that tends to be too much laxity in the joints. The ligaments aren't doing the stability as much as they should, and that happens all through the body. Now in the feet, if that happens in the arches can collapse, and that will actually lead to this kind of postural collapse that you're seeing. Now after a few years of that, the body's going to adapt. It isn't going to just keep things all loose. So her serratus anterior has probably contracted, maybe some of her high pec fibers and so on have shortened adaptively to take up slack so that things are less dangerous. Again, you're looking at what's the logic of the body in this stuff. Some of the muscles in the back, like the trapezius, become long and weak, functionally weak. Not that you want to put the person on bands and try to strengthen them. That doesn't work, and we see that all the time with physical therapy. You have to do the body work first. You have to release the muscles first and get them so that the person can actually function properly. Then you start to strengthen. And for a hypermobile person, strength is a good thing, but the order of events is critically important. This is why people often fail these types of treatments, because they try to push it too fast, and you try to overdo the strengthening in the beginning, and it takes muscles that are already really dysfunctional, only have a few fibers that are working correctly, and it makes the muscle even worse. And then the person comes out of it with worse pain. So dealing with the scapular misalignment and the perpetuating factors, in her case, I would say we'd probably put her in corrections, arch corrections, possibly leg length difference as well. And that'll help with the postural collapse, and then doing the body work, self-care, and then probably, eventually getting into some rehabilitative exercise, corrective exercise. The scapula has to rotate in order for you to raise your arm all the way up. If it doesn't, so if this shoulder blade does not move, then what's going to happen is eventually that arm is going to actually run into the bone of the top of the shoulder blade, and the muscles that are responsible for moving the arm are going to be troubled because they're trying to push against this incredible resistance. So you have to get the scapula functioning correctly. So we say we're improving scapular positioning, but also scapular rotation. When you do that, then the body's getting different neurological signals, and the rotator cuff muscles and some of these other muscles are going to be much more calm. You'll be able to then make some progress in terms of your therapy. So this is our muscle liberator tool that we use in therapy. We have a version of this now for self-care that's a little bit lighter and quieter, but this is incredibly valuable. And it's valuable primarily, as I said, as a distractive tool, because the distraction it provides to the nervous system allows things to release much more quickly. It's not about pounding. You don't need to pound muscles into submission. That's kind of what people think these percussion tools are about, and that's not actually how it functions. That is kind of a short-sighted view of it, and it's not ultimately what causes the nervous system to release. The nervous system releases when it starts to see that positioning is correct, some degree of movement is possible without pain, other muscles are not inhibiting motion. So we have to set up that situation for the body so that we can start demonstrating to the central nervous system, well, you can now move this far. Before you couldn't move your arm from your side, now you can move this far without pain. And then it downregulates. And then, so that's what this Liberator's just revolutionized our treatment. And we use this tool on ourselves with self-care. I'm going to show you another tool that we're going to be using with people for self-care that's actually quite nice as well. That's the Muscle Liberator Mini. We have done a lot of research, and this tool is very much like the Hypervolt might be a tool you've encountered, which is about a $350 tool. This is quite similar to it, another manufacturer, and we've done a lot of work with it, and we're very happy with it. And so we sell this now for a regular price of $150. The nice thing about it is it's very light, it's quiet, and it's something you can do in a self-care environment very easily. Comes with a lot of heads, and then we have also designed our own head, and this is a big part of what makes our Muscle Liberator so effective is the head. We have worked with the silicone the compressibility of the silicone is very important, to have it not too soft and not too hard, and then have the stroke length of the tool be correct. So we've had to do a lot of experimentation, and we designed these heads ourselves. We have designed a head now that can be used with a Hypervolt, or it can be used with any of these types of tools as well. So now you can really do a form of this coaching body approach with a much broader variety of tools. So what I want to talk about today, we've released a self-care course that incorporates all of these ideas for people that, right now it may be very difficult or impossible for you to see a therapist. And in any case, even when you are seeing your therapist, to have these tools and be able to do this work on your own in between sessions is going to make things go much, much faster. And the body, when you're doing self-care, it gets better faster because you're actually down-regulating your own central nervous system much more quickly. So this includes an explanation of all of the anatomy, but in more layman's terms. We normally teach therapists, but in this case, we're actually teaching people that may have not studied anatomy at all, which is fine. That was Claire Davies' audience also. And I enjoy working with people that don't know anything about this work. So you get a lot of reference materials, you get, explanations both through video and through our workbook of the muscles that are involved and the order of events, and then detailed explanations of how to treat each muscle with various tools, including a protocol for going through all of the muscles, a shorter version and a longer version. So it's a fantastic resource. And I want to show you a little bit here. We have some video excerpts from the course, and then we'll run this for a few minutes, and then after that I'm going to bring Doug Ringwald in, who he's taught a lot of self-care work. He's in a lot of the videos he's done, helped me develop a lot of these techniques. So we're gonna get Doug's view of some of this as well, and show you how you can get involved. So okay, Zoe, you want to run that video? So in the shoulder, we have two components, and you have the shoulder blade. The shoulder blade really serves as a base that the arm moves from. So in order to have complete range of motion, this scapula or shoulder blade, that tip is pretty close to his spine. Now let's just raise your arm to the side, and I'm following his tip. You see how that moves. So that moved way out there, which is good. And let's do it one more time. So we call that scapular motion, scapular rotation. So that scapular rotation is necessary to have healthy shoulders. The main muscle here that we're looking at is going to be the trapezius, or trap. So the trapezius, this is the ridge of the shoulder blade, and a lot of these muscle fibers attached to that. The low trapezius goes in a direction that's down like that. And let's hold your arm out in front. Now you see, you can actually see the low trapezius fibers. Those are necessary, or his scapula would just fall forward. So we have to have something pulling this back as he lifts his arm in the front. And so we see these angled fibers coming out. And so that's the nature of muscles. They have different fiber directions. In the case of the trap, it's like a big clock. So as you get up in here, these fibers are going to start to angle up and farther up until they come all the way up into the head, and that's the high trapezius fibers. This is all high trapezius here. So you can see it has a lot of different fiber directions, which means it can move the scapula in a lot of different ways.
The first thing that we'll address is scapular movement. The scapula, very important. Anytime we're moving the arm, the scapular muscles attaching the thorax to the scapula, have to stabilize the scapula. So even if I'm raising my arm up like this, the scapula has to move. The muscles that are attaching to the scapula have to coordinate happily together the stabilization. So the scapula has to be able to rotate, it has to be able to protract, it has to be able to retract, and this is the foundation of proper shoulder functioning, is scapular positioning and rotation. So we're going to start with that, and we have some great ways of addressing that with compression and vibration around the whole scapula with the movement. So first we'll start with the tiger tail ball, and Will's going to place that in between his scapula and the spine on his upper back. And I want him to kind of move up and down a little bit until you find, a place that's a little bit tender. Right? That generally is going to be your low trapezius. So that is a very important scapular stabilizer. So he's going to get compression on that. And this muscle, when it doesn't perform its function because of taut fibers and muscle dysfunction, it lets the scapula just position itself forward. So we want to be able to retrain it to be able to bring the shoulder back. So we're going to do that by moving the scapula with compression on that low trapezius. That low trap compression will distract the muscle from a pain response while we're putting it through its range of motion. So that's step one. The tiger tail ball is in that low trapezius area in between the spine and the scapula. Then step two is Will's going to use the liberator along the lateral border of the scapula. So here's the scapula. I can feel the medial border. It comes down here. There's the inferior angle. And then here's the lateral part of it right here. So he's going to use the liberator just in front of that lateral border, close to the ribs, actually along the ribs and along the muscles that live here, while he does scapular movement, forward and back, and also lifting the scapula up and pushing the scapula down. So he's moving his shoulder. He's not concerned with moving the arm. It's all right here.
Okay, so I just wanted to give you a little bit of the flavor of this this course, and I'm going to bring Doug in. So our ideas basically are the same in self-treatment as they are in therapy. And what we do in self-treatment is we follow the same analysis, and then you treat the relevant muscles, you do some movement. So depending on what compression tools you have, you might do different techniques. So you can use balls, you can use tennis balls or larger balls, the therapeutic vibration tool, you can use a cane type of tool. And so we show, different examples of all that. There's over 3 hours of video in the course that we're explaining exactly and how you do this and what order you do it. So I'd like to bring Doug in now, and let's, Doug, maybe talk a little bit. I know that you've worked a lot with the self-care techniques yourself, but also with your clients. So how do you feel about the effectiveness of self-care and how that all works for you?
Yeah. Can you guys hear me?
Yep.
Okay, good. Yeah, so self-care. I've always been interested in self-care because I came at this work. Originally, I was a yoga teacher. Before I get into yoga, I was a pretty serious athlete in basketball and tennis, especially soccer. So I've had my more than my fair share probably of different types of strains, actual injuries, and other things that kind of kept me sidelined. And when I was a yoga teacher, I basically got into that because of my own back pain. Like, even though I was very active, I would still have crippling bouts of back pain that I couldn't really get any help with or really understand. So once I came to study with Chuck, that kind of transformed my whole understanding of where pain comes from and dysfunctional movement. And well, that really helped me be able to treat my own pain, my own back pain. And yeah, I mean, I like getting body work and I like getting help, but I also don't, I just don't like to rely on people. And if I have a problem, if I encounter some type of issue, because I still like to be very active and play sports and things like that, I want to be able to fix my own issue, and so I've always had a very strong interest in self-care. Also, as a therapist, instructing people in self-care and being able to care for myself. One of the very valuable things about self-care is that it actually is a pain down regulator in and of itself. Because if you feel disempowered, where you get some type of pain issue and it cascades and you really feel kind of helpless, well, that's like a snowball rolling downhill that gets bigger and bigger. If you understand where the pain is coming from and you can help yourself and start to downregulate that pain, then you are empowered to help your own situation, and that helps unravel the pain also. So it's just a very important aspect of pain and resolving pain issues is self-care, either working with a therapist or working on your own. So when I was doing a lot of therapy sessions, I would always, and still do, always leave 10 or so minutes at the end of a session so I can instruct the person in how to keep their own pain resolution keep happening for them, how they can most successfully treat pain themselves. And because of this empowering thing that happens, and also at the end of a therapy session, I usually have it pretty figured out what's the most efficient way that this person can help themselves. What one or two muscles can they really address with their own self-care, so that they can get the most benefit and keep their progress, and even improve their own progress and be on their own and not even need me for another session perhaps. And that has always worked out really well. So over the last 4 or 5 years, I've been very engaged in keep refining these ways of treating muscles for people, how they can treat the muscles on their own, no matter what types of tools they have, different types of compression tools or vibration tools, which is our preferred method, because that power of vibration, of the distraction, it really lets you gain movement as the distraction your nervous system from the pain. So, and then once your body feels that restored movement and you're not getting pain at that end range anymore, that's that down regulation that Chuck was talking about, and then it keeps expanding after that. So the self-care has always been a part of my personal practice, part of my therapy practice. And the years that I've spent with Chuck, the last 4 years or so, we've really been refining the self-care and making it as efficient as possible, especially in terms of being able to, be able to describe and figure out where the pain is coming from, using our protocols basically in order to figure out where the source is. Because if you don't treat the source, it's gonna, it'll feel good for a little bit and then it comes back again. You treat the source and then you can keep your progress and keep the pain away and get into active movement and then into strengthening and then you're not doing the self-treatment anymore. You're just doing active movement and living life, and that's where we all want to be. So it's been a great journey with Chuck over these last years in refining this. And I've actually, I was, up until, a few weeks ago, probably like maybe many of you who are therapists on this call, I was very active doing body work and manual therapy and helping people in that way. And then that suddenly came to a big grinding halt. And so then what I've done is I've switched to doing more online coaching with people and basically taking these self-care techniques and coaching people in how to use them by online means. And it's been very successful. And the people I've helped with that have been very enthusiastic about being able to treat their own pain and about the results that they've been able to get. And I was actually kind of quite amazed when I started doing this type of online coaching of how I could, combining that with the ability of doing the online video, and I figured out ways of having other cameras involved too. I'm really quite happy with the results that I've gotten with clients just with this online self-care approach.
Yeah, and you've had some great results. I know both in the area of sciatica and shoulder pain, and Doug actually has been working on our self-care sciatica course that'll be released in probably a couple weeks. That's the other big pain indication that we see. So I know you've had a couple cases where people have been able to really make a serious dent in their own pain by you kind of coaching them with these ideas. Now, what we're trying to do with this course is give you a tool that you can use on your own. You don't need a remote coaching to be able to be successful at it. That's just more of an accelerator. So if you do have a therapist who's studied our work and understands, we have a lot of people out there now that have, done some study with us, and they could be a resource for you during this time, even remotely. So you can do, what we want to do with the course and this offer is to get the course in people's hands, get the vibration tool available to them, and then also, if they need it, to additional support. That's something we do with clients, and it's something perhaps your therapist, that if you already know somebody, may also be able to do. So the course itself is going to consist of these protocols where we're moving through the shoulder muscles in the order that makes the most sense, and then you can also make some, changes to that, but we tell you about, how to focus on the most important muscles, because the idea is not to be doing hours and hours of this work a day. When I do self-care on myself, I'm trying to just keep it down to maybe 5 or 10 minutes per session, and I might do a couple of those each day. You don't want to do too much. For one thing, people tend to not do it and comply if it's too difficult. But you also have to give the muscles an opportunity then to assimilate the change and move, and then you go about your daily life. But I think what we've seen is this allows you to perhaps sleep better, to do some of the things you love to do, activities, sports, and so on. And then at some point we will be able to do therapy again. And, at that point you can resume that. But I would say even with that, what we found is the most effective therapy is when the person is doing self-care. and I would always give my clients projects, and it makes a difference because you're basically making a statement to yourself that you know how to get out of this problem. And as Doug said, that downregulation and empowerment is just a critical thing, especially now in what's happening in the world today. So that's why we're so excited about this. So we talk about a lot of different tools using, there's muscles, and we devote a lesson to each type of tool, pretty much for each muscle, the most appropriate for that type of muscle. And then what we decided to do right now to make this as accessible to the world as possible is we've taken our course, which we already had, and we're putting an offer together for those that are attending the webinar today. So instead of the regular price of the course alone, which is $347, we're actually going to put together our Muscle Liberator Mini, that other vibration tool, the little bit lighter one that I was showing you, with the course, and the combination is only $297. So it ends up being about a $200 discount, So that's kind of what we're trying to do to make this as affordable and accessible as possible to people. And we're going to make this offer available to you for the next several days, so you'll get some follow-up emails about that. And certainly, we're going to have a little time, I hope, to take some questions here. But if you don't need the tool, if you already have a Hypervolt or some other tool, then we can give it to you for $237. We're trying to, make that as aggressive as possible. And this stuff works, it works really well. And, these are the same techniques we use on ourselves and the same techniques that we give to our clients. So this link you see at the bottom, TiBiotic.com/shoulder promo, is where you can take advantage of this offer. You can always hit us on chat if you're having trouble with that, and we will send you some follow-up emails about how to do that. But, what I'll just say here is that this, I found with my own pain, I used to have a lot of pain, and by applying these same techniques and then understanding what sets the pain up, I, at this point in my life, have very little. I've pretty much gotten out of it. But I know that I can work with my own issues if I need to. I very rarely, would have to see somebody else. And sometimes, that's just a nice thing to be able to do. So it's very empowering. And so what I'd like to do now, Zoe, is if we have some questions, we'll try to address a few of those. We don't want to let this go on too long, but how are we doing with questions?
Yeah, we have time to answer a couple, and I just wanted to put out to folks that due to our technical issues earlier, I'm not seeing the ability to actually show you. Give you the offer link. So I'm going to post it. I'm going to have to post it in the chat so you can grab that and stick it into your URL. And we'll do the same with the slides. But I did have some questions from folks. One was in regards to supplements for the training, whether there is any kind of textbook or supplements to the work. I'll let you cover that.
We do provide a workbook. It's a PDF. It's not a hard copy book, because that way it's just easier for us to get it to you, and you can view it on any of your devices. So it's a fairly extensive workbook that goes through the background and all the muscles and the protocols of what order to do things in. So that is part of what we provide.
Great. Just In general, can one person had been asking whether there are any CEU credits for this course, specifically for Ohio, but we can answer that just in general.
We have not. I don't think, have we, Zoe? Have we applied on this one?
No, we have not applied for this one, largely because it's we haven't been focusing it towards LMTs.
Yeah, I mean, it is valuable information. So, and we're a long-standing NCB/TMB CE provider. So usually it's pretty much a rubber stamp for us to bring in a new course. So we can, if there's interest in that, we can certainly get some CE credit for that.
Chuck, can you answer this question? Can I use this with a C1, C2 subluxation?
Well, so you have to look at why do subluxations happen, And this is always kind of the dialogue with this type of, a lot of people want to focus on joint alignment, joint play, and so on. And that's certainly an issue, but, muscles, we're just a bag of bones without ligaments and muscles. Muscles are what position bones. And so we have anatomical forces and alignment forces from the bottom, from the feet, and then you get into leg length, you get into postural collapse, all the way up the kinetic chain, to the top of the spine. So in our system, we would be looking at, if that is something you're prone to, atlas axis, sublux, why does that keep happening? And from a structural and a muscular point of view, what is setting that up? Quite often, it is asymmetric forces on muscles that bring things out of alignment, and then you have an interaction. So the muscles disturb the spine, and they, bring segments into the improper alignment, and then possibly you might have a nerve being pressed on because of the alignment issue, and then the nerve innervates muscle. So you've got a loop going on. Then the muscles that are in that neighborhood start to become hypertonic and develop trigger points. So we try to normalize the symmetric alignment of the body in general by correcting leg length and hemipelvis length, things like that. We normalize the behavior of the muscles on both sides of the body and try to create free movement, pain-free movement, and proper range of motion. And so working with specific, joint issues is not a problem because you have to look at it as a whole. It's not just that you're stuck with this subluxation, so can you do the muscle work? We just don't see it that way. And everything we do is done with a lot of monitoring. It's done, not with ballistic force or anything like that. It's done very, very carefully, so we don't have a safety issue with it.
Great. We had a question about not just the shoulder, but do we also have self-care training for the lower body, specifically hip pain?
Yeah, Doug, do you want to address that? Is Doug on?
Yep, Doug's here.
Okay, I just unmuted myself.
Great, thank you.
Yeah, actually, we do have a self-care course in sciatic. I'm editing it right now. So we've been shooting it over the last couple of years, and I'm putting it together. And so we hope to have it ready to go in a couple weeks. So yeah, that is nearing completion. And the sciatic, we call it our sciatica course. It's a lot of lower body pain is derived from the glute muscles, from the glutes and the adductors. The glute minimus muscle just by itself can produce all sorts of lateral sciatic symptoms and posterior sciatic symptoms all the way down into the calf, into the foot, into the plantar foot even. So we use the same coaching the body approach with sciatica that we do with the shoulder, and it's a matter of figuring out where the pain is actually coming from. And in the course of with hip pain issues, it's a lot of glute and adductors and everything in the lower body. There's usually a huge component from those muscles. So that course is in the works and nearing completion.
And just to clarify that term, sciatic pain. So Travell and Simons talk about that sciatica is not a diagnosis. And people assume when you hear that word sciatic or sciatica, you're talking about the sciatic nerve, and that is just simply not the case. It's an indication of a radiating pain pattern, that may begin in the low back and the gluteal muscles and the hip area. It may involve sacral pain. It may have components that radiate down. They may only report something in the lower leg. These, from a trigger point of view, are all the same thing. And so that's just kind of our shorthand for referring to the lower body. But this really is our lower body core protocol, and being able to do, elements of that on your own. And I think didn't you just have a session a few days ago where you completely eliminated somebody's pain with self-care, Doug?
Yeah, I've had a couple coaching sessions with a client in Oregon, just with online coaching with Zoom, and he's a hip replacement candidate, pain in the anterior thigh, and also into the posterior glute areas, and I've trained him in self-care, and he's had, for the first time, in years, he's had no pain. He's had days of zero pain, and he knows how to, when he starts to get pain, he knows how to treat it himself. And that came about from the coaching, but also of figuring out that he has a leg length difference, and that was kind of setting up the whole problem on that one side of his body. All his pain was on the right side. So that was very successful, and so I've had a couple sessions with him. He got a lot of benefit after the first session, but especially after the second session, that's when he started experience. When we really dove into some of these specific muscles in order to treat those himself. That's when he started really getting pain free.
And so, the coaching or the remote sessions are useful to accelerate or to guide the people with, which muscles you do in what order. A lot of that is already in the course. It just might not be as efficient doing it on your own. So you don't need it. It's nice, of course, to have a consultant or an expert who can help guide you. But the whole point of this is that we can. And that was Claire Davies' whole thing. When he wrote his first book, it was doing trigger point work on yourself. It wasn't oriented toward therapy at all. And it is very, very accessible if you understand the analysis and what muscles are important. Because what people tend to do is, if you're, a common one in the lower body is you might have what somebody would call IT band pain, may go into your knee or may just be the side of your leg or whatever. Well, we consider that just to be another case of the same type of muscle referral. And then other people might identify it as an IT band issue, and then they roll their IT bands. Well, in trigger point terms, that would be kind of just rubbing in the wrong spot, rubbing where it hurts, because usually where you feel the pain is not where the problem is. So that tends to be a waste of time. So if nothing else, these courses teach you what the sources are of these pain issues. And just knowing that's the amazing tool that can get you out of pain, rather than trying to, the front of my shoulder hurts and I rub that all day and it feels good for 20 minutes, and then it's right back again, So it's that deeper understanding of these patterns that is really important.
Great. I'm just going to ask one or two more questions, and then we've got a ton of them coming in. I do want to wrap this up for folks. Is there anything else that comes with the training other than the Muscle Liberator Mini and the PDFs?
Well, there's over 3 hours of video that cover, using all of these tools in detail. And you do have slides and documents that we've prepared. We have the workbook. So there is a lot of written material too. It's just, online written material, but you're free to download that and print it. There are other tools available. So we do distribute the Tiger Tail tools, or you can buy those on Amazon or whatever. They're balls and things like that. Those are fairly inexpensive, but we didn't want to encumber this offer with that, because for us the vibration tool is the central part of it. That's what I think our system exploits really importantly, and so we wanted to get that to people and keep the cost down as much as possible.
All right, great. Thank you. Last question I'm going to take right now. They're still streaming in. Folks, I am going to make sure that each of you does get a response from me via email for those of you who do not get your questions answered. I have someone whose husband has a slap tear and a torn labrum, and the PT seems to think he doesn't need surgery. I'm wondering what your thoughts are.
Yeah, so whenever there is an actual verifiable joint disturbance, an example would be a tear, or rotator cuff tear, which is usually the supratendon and so on. Well, the tear is a source of nociception. So, in other words, there are little sensors in your shoulder that are like your oil sensor in your car, and they're going back to the computer and saying, something's not right. It doesn't mean that, and go back to Lorimer Moseley, soft tissue damage is neither necessary nor sufficient for pain. So the pain is a separate issue. It is the body's response to what it's seeing as the condition in that area. Now, if you have the slap tear, labral tear, you are getting nociceptive input to the nervous system, which is going to upregulate the central nervous system, and it is going to make you prone to have pain. It isn't necessarily causing your pain. What causes your pain is use of the muscles that are splinting then in response to that, and that can cause a ton of pain. So my experience has been with these types of actual injuries, you also have to look at the joints are positioned by ligaments and muscles. So you have muscles across the joint. If you have muscles that cross your shoulder joint and your head of your humerus is being jammed up into the glenoid fossa, you are going to have eventually connective tissue damage because you don't have proper joint clearance. So there's an interaction. The muscles can actually set up the joint problem. You create more joint space by relieving some of the hypertonic muscles that cross the joint, and then the body has an opportunity to start to downregulate and even lower inflammation in the joint itself. And I believe that's what happens in frozen shoulder. So you can't look at it as the one-way street where the injury is the start and everything else flows out from the injury. That's just inaccurate. It doesn't work that way. Your muscles are what cause most of the pain. They can cause much of the actual issues in the joint. Rotator cuff, that's usually the supraspinatus tendon, which sits right underneath the bone, the acromion, which is part of your shoulder blade. And when the muscles get tight, they tend to pull and jam that tendon up against the acromion, well, it's going to develop a tear. It's going to develop fraying, and that's because of the positioning issue. So you have to treat all of those muscles that position the head of the humerus in the shoulder and get those normalized. And then the body has an opportunity. So the fact that the PT is saying surgery is not appropriate is a very, very good thing. And I think, that could very well be quite responsive to these techniques.
All right, folks. Well, we've got to wrap it up. We've kept you. So thank you so much for joining us. I'm going to see if I can get actually Chuck, if you take out your slides and can join us. I just want all of us to be able to say goodbye to everybody together. I've copied all of the, let's see, 1 second. There we go. There we all are. I've copied any emails that or any questions that have not been answered. So you should be getting an email from me shortly if your question was not able to be answered, either from myself or from Emily. So thank you all for joining us today, and stay safe and healthy.
Thanks, everybody. I really appreciate your joining us. And, there is hope for your personal pain or that of your clients and the world at large, which is in a challenging place right now. But we're all trying to do our part to make things a little bit less anxious and easier, and stay safe.
Thank you.
Bye.
Bye-bye.
Let me end. Is it gonna let me end? It's not gonna let me finish the webinar.
Like shutting down a 747.